Welcome, everybody. Welcome to the Newborn Toolkit webinar. Welcome to the webinar. We're having this webinar in collaboration with PATH. Today's webinar is in honor of World Breastfeeding Week. Happy World Breastfeeding Week. Today's topic is, why does breast milk matter even more for the most vulnerable babies? Welcome. Please introduce yourself in the chat. Next slide, please. Welcome once again to the Newborn Toolkit community. This series aims to encourage collaborative learning for faster progress together. Our 2024 webinar series is structured around the WHO UNICEF 10 core components of small signal-born care. Today's topic, once again, is why does breast milk matter even more for the most vulnerable newborns? And we're having this webinar in collaboration with the amazing PATH team. In 2023, the Newborn Toolkit had over 28,000 users from more than 170 countries, and our user base keeps growing and growing, and that's thanks to you, our Newborn Toolkit community. Please join the Newborn Toolkit community. On the screen, you see QR codes for our newsletter in French and English, and also a QR code for our social media channels. Next slide, please. Welcome once again to our webinar, Why Does Breast Milk Matter Even More for the Most Vulnerable Newborns, hosted by the Newborn Toolkit with PATH in honor of World Breastfeeding Week. We have more exciting upcoming events. On 20th August, we're going to be having a Spanish webinar in collaboration with the PAHO team. And the title of this webinar will be Data for Action Across LAC for Neonatal Quality and Equity of Care. And on 10th September, we're having another vibrant webinar in honor of World Sepsis Day. And the title of this webinar is Babies and Bugs, Innovations to Address Neonatal Sepsis and AMR. Welcome. Please introduce yourself to the chat. Next slide, please. And now I'll hand over to Lauren. Lauren.
Merci. Alors, bonjour et bienvenue à tous nos participants parlant français. Si tu veux écouter le webinaire en français, tu peux cliquer sur le bouton de traduction affiché en bas de l'écran pour accéder à la chaîne française. On a aussi quelques webinaires à venir. Le 20 août, des données pour agir dans la région ALC en faveur de la qualité néonatale et de l'équité des soins. Et le 10 septembre, Bébés et microbes, innovation pour lutter contre la septicémie néonatale et les résistants aux antimicrobiennes. Alors, veuillez introduire dans le chat en indiquer votre rôle et votre nom et le pays d'origine. Next slide, please. So we're very excited to have Dr. Emily Njuguna here today. She is a pediatrician and global health expert. She's the African lead for maternal and newborn health at PATH and the nutrition lead for the African Neonatal Association. She advocates for better nutrition policies for infants and vulnerable newborns in resource-limited settings. So a warm welcome to Dr. Njuguna, and I will pass over to her to take it from here.
Thank you so much. A warm welcome to you all wherever you're joining us from. We are very excited about this webinar in commemoration of World Breastfeeding Week 2024, whose theme is Closing the Gap, Breastfeeding Support for All. This year's theme seeks to highlight the need to support particularly vulnerable groups to succeed in breastfeeding. And this is because we know that breastfeeding has a critical role to play in ensuring the survival and thriving of children. Globally, we know that newborn mortality rates have stagnated, and many countries, particularly those in sub-Saharan Africa and Southeast Asia, are unlikely to reach the SDG target of 12 deaths per 1,000 live births. A large proportion of newborns who are dying are small and sick, and that is those who are born too early or too small. And they are particularly vulnerable and need extra support to receive breast milk, which is vital for their survival. Therefore, in this webinar today, we will highlight why it is necessary to provide the appropriate support to moms and families of small and sick newborns so that they can receive exclusive human milk diets to ensure that they survive and thrive. And in this webinar today, I will be joined by very special colleagues. We have Ayebaale Gorret, who is a preterm mom who delivered in 2020 and now a breastfeeding specialist at Mbale Neonatal Unit in Uganda. And Ayebaale offers vital lactation support to mothers inspired by her own challenging neonatal journey. We will also have a session by Esther Nandete, who's also a preterm mom, and she gave birth to her precious baby this year and has benefited from Gorret's lactation support and the Human Milk Bank in Uganda. Both of them will be speaking about lactation support counseling from a parent's perspective. And after that, we will have Dr. Elise Van Rooyen, who is the head of the KMC or Kangaroo Mother Care Unit at Kalafong Hospital in South Africa. And she has been the head of that unit since July of 1999 until December of 2021 when she retired. Until recently, she was a consultant for UNICEF SRO office as a technical advisor and is currently an extraordinary member of the Department of Pediatrics at Kalafong Hospital. Elise will be speaking about the evidence of the overview of breastfeeding for vulnerable newborns and why it's important. Thereafter, we will have Kimberly Manson, who is a maternal and newborn nutrition advisor at PATH with the Integrated Maternal Child Health and Development Unit. And she is a trained dietitian, nutritionist, and has experience both clinically and within the global health field. Kimberly will be speaking about the development of the WHO Human Milk Banking Standards. Then we will move on to Patrick Toh, who's a neonatal nurse working in Kenya, and he is also the chairperson of the Society of Neonatal Nurses in Kenya. And he is also a board member of the Council of International Neonatal Nurses, or COIN. Patrick will be speaking to us about the need for specialized lactation support because of the unique needs of small and sick newborns and their mothers. Thereafter, we will close with a question and answer session from Kirsten Israel Ballard, who leads PATH's Integrated Maternal Child Health and Development Program and is also an affiliate associate professor at the University of Washington. Kirsten has over 20 years of experience in infant and young child feeding, and she focuses on feeding method HIV in developing countries. So without further ado, I invite Ayebaale and Esther to start us off in this webinar. Karibuni sana.
I'm a preterm mother. I happen to have delivered a baby at 24 weeks gestation. So through my experience in motherhood and a preterm mother, I got hardship in breastfeeding my baby. I didn't have enough breast milk supply. But it's through hardlining and practicing and patience, I ended up achieving enough supply for my baby. So at the end of it all, I got enough breast milk for my baby. So I continuously breastfed for 2 years. On a daily basis, I do breastfeeding classes. I teach mothers how to breastfeed, how to express the milk, also how to boost up their supply. Also, I counsel some mothers. Sometimes they also go through challenges, exactly what I went through. Even some others, they go beyond where I went through. Actually, every morning I go in HDU section and look for babies who are new. I want to begin with that mother who has just arrived in the hospital so that he doesn't be scared with what he has seen, so that he gets used very, very fast. My role, I see mothers very, very fast, those who have just arrived, so that they are not yet emotionally affected. I just make them feel the journey is so soft. Just like the way I went through, they can also still go through it. As a preterm mother, now that I'm skilled, I know when a mother gives birth before 9 months, sometimes the hormones responsible for producing breast milk, they are not yet ready. So it takes some few days, 2 to 3 days, when the milk is not yet, the supply is not yet ready, or when the reflexes are not yet. So I talk to them, it is normal, feel normal. I myself, I went through the same. So it's not you. Others were here the other year, others were here yesterday, so today it's you, tomorrow is another person. So they also feel, okay, I thought because I've given birth to a premature, and now again I don't have milk supply, maybe there is a curse on me, maybe my judge did something on me, so they feel it is normal. At first it was so challenging. People don't want to donate breast milk. It was so challenging, but through awareness, people now know they are giving out gold, they are saving people's babies' life. And not only, actually when I'm doing awareness, I tell them you're not just saving a baby, but you're saving the whole world. When you lose one baby, the whole world has lost an important person. So you find in the process, mothers have picked up. It's all about breastfeeding. Whether the mother is there, whether the mother is sick, whether in any condition, we have to breastfeed. And the breast milk for the mothers, from the mother's own baby is the best. But in an instance where the mother is not there, then donated breast milk is the best, is the next option.
My name is Nandete Esther, and I'm a recipient from the Human Milk Bank from Bale Regional Referral Hospital. I got an operation at the gestation age of 37 weeks. But my baby was as small as 1.2 kg. It was really hard for me to take because I'd never seen such a small baby on my side. I felt so stressed and frustrated when I realized that I could not produce enough breast milk for my baby, because the fact is I know that babies have to begin taking breast milk right after birth. So on my part, I didn't have any, because I tried to press, but there was nothing coming out. It was really hard for me because I knew that my baby was going to starve due to hunger. Lucky enough, I got support from the breastfeeding specialist, Gorret. She helped me by supplying us with breast milk for my baby to feed on. And it really helped me a lot because I felt more calm knowing that my baby had what to feed on, as I was like preparing to also produce enough breast milk for her. Yeah, so I was so relieved knowing that my baby was not all that starving. The breastfeeding specialist, Goreti, told me that all I needed to do was to eat well, get satisfied, and I was not to like keep worrying about breast milk, so that it would help me produce my own, because the fact is, when you're not feeding well, you cannot produce enough breast milk for your baby. And if you keep worrying a lot, it can still affect the production of the breast milk. So she told me to just relax, as she was helping me out, that I keep feeding well, yeah, up to the time that I was able to produce the breast milk for my baby. The experience, okay, what I felt about my baby receiving donor human milk, at first, I was a little worried because I was imagining where was the milk coming from, who was donating, what. But then later I got to realize that actually the milk goes through a safe process, and it is also kept well in a refrigerator. So I gained confidence, and I was like, yeah, the milk is safe and okay for my baby to take. What I would like to tell other mothers whose babies may need donor human milk is that they should appreciate the fact that other mothers are donating milk for their babies, and they should also trust that the milk is really safe, because my baby never got any issues because of donor human milk. The baby is very fine, even up to now, she is doing very well. So they should just appreciate the fact that other people are able to give them breast milk, and they should not worry about anything, because the milk is very good and safe. If I'm given a chance to donate, I would definitely do it, because what the I really felt so good that someone else was willing to give my baby breast milk, after, like, without even knowing who my baby was, or who I am, but someone out there is willing to donate milk to my baby. So I would definitely donate if I'm given chance. I would also be willing to support any other mother who doesn't have enough breast milk for their baby.
Thank you so much for that insightful talk. At this point, I will invite Dr. Elise van Rooyen to come on board and discuss the evidence overview of breast milk feeding for vulnerable newborns. Welcome, Dr. Elise.
Thank you. Can we start with the slides? So I'm going to talk about introducing a feeding resource document for vulnerable newborns, and also evidence overview of breast milk feeding in very short. Next slide. So you may wonder why there was a need for feeding resource document. This initiative started with a mapping of newborn care documents available in the Eastern and Southern African region in 2021, which was a joint project of UNICEF, ISARO, and the University of Pretoria. From the analysis of documents, feeding preterm and low birth weight newborn was identified as a critical gap. Next. Major feeding gaps included lack of quality information on the feeding of preterm and low birth weight newborns, feeding practices based on outdated information, some of which that could lead to higher morbidity and mortality, and little standardization of appropriate feeding practices was found. Next slide. Further, they found that the examples of harmful practices that could lead to higher morbidity and mortality was like delay in introducing enteral feeds, too slow advancement of daily feeding volumes, inconsistencies in calculating feeding volumes, timing of introduction of oral feeds was either too early or too late, late introduction of feeding directly from the breast, misunderstandings of the feeding needs of small and sick newborns, and scheduled feeding and not responsive feeding or feeding on demand. And there was the role of breast milk fortification was unclear, incorrect feeding positions for small babies with poor body support of the babies. Next slide. Next slide. So the aim of the presentation is to give a background of development and uses of the preterm feeding document, to provide a short introduction to the content of this document, and to give a short evidence overview of breast milk feeding in preterm infants. Next slide. So the resource document was developed for healthcare providers to understand the complexity of feeding small and sick newborns, and also for countries to easily find current theoretical and practical information, and so that they can draft country-specific guidelines and standard operating procedures. Next. So this is a living document based on the latest appropriate global feeding evidence, and it is also updated regularly. Next. So this is what the document looks like, and I will give a short review on the content of the document. Next slide. So the document is arranged in 4 main sections: an introduction, complexities of feeding small newborns, breastfeeding and breast milk feeding, alternative methods of feeding, as well as some annexures with practical resources. Next slide. So this diagram illustrates the complexities of feeding small newborns. The yellow triangle represents the extremely small and premature newborn that are unable to receive only enteral feeds, but need intravenous fluids and parenteral nutrition. The patterned middle triangles include a diverse group of neonates. Some neonates may only receive enteral nutrition via a gastric tube, while others may receive enteral and oral nutrition, and some may even be able to start direct breastfeeding. And the gray triangle illustrates breastfeeding and how important role breastfeeding plays. Breastfeeding should be introduced as soon as possible after birth, and it starts with the provision of colostrum within the first hour of life. Next slide. The second section describes, include information on early feeding, total parental nutrition, non-nutritive sucking, enteral feeds that include application of oropharyngeal colostrum, trophic feeding, and the advancement rate of enteral feeding, and also discusses feeding intolerance and complications. Next slide. So the next diagram I want to discuss is a timeline of when enteral feed should ideally be introduced and the transition process from tube to breast and cup feeding. Next slide. So this diagram illustrates the timeline of introduction of enteral feeds and transition to oral feeding. And these are demonstrated by these different colored arrows. At birth, enteral feed should start as soon as possible. And the red arrow displays the importance of giving colostrum to all small babies as soon as possible after birth. When enteral feeds are given in small volumes, it's called trophic feeds, the yellow arrows. And all enteral feeds should be given via a gastric tube while baby is in skin-to-skin position, which help with the feeding of the baby. As soon as the baby is hemodynamically stable, non-nutritive suckling on the empty breast should start, the green arrows, and this practice helps the baby to learn how to breastfeed. As soon as the baby is more mature and shows signs of feeding readiness, cup feeding is introduced, the purple arrow. And tube feed volumes are slowly then reduced and cup feed volumes are increased. Next slide. So the rest of this chapter also includes feeding progression and transition, a feeding activation program, intervention, when to discharge, and then also when to follow up the baby. Next slide. There is a chapter on breastfeeding and breast milk feeding, and it includes breast milk benefits. And I just want to discuss a few points of the importance of breast milk in vulnerable infants. Next slide. So current research substantiates that human milk is particularly beneficial for vulnerable newborns and it significantly reduces complications. Benefits of the breast milk includes the immunological and antimicrobial components that are important to build resistance against infections. Next. These host defense factors also lead to fewer overall infections. There are significant reduction in the severity of hospital-acquired infections, and there are virtually no episodes of necrotizing enterocolitis. The practice of KMC enhances the creation of antibodies that defend against particular infections. Next slide. Breast milk is well tolerated, easily accepted and absorbed, and particularly by extremely preterm babies. It supports speedy attainment of enteral feeding, and it contains growth factors and hormones that enhances and protect brain and neurodevelopment and reduces retinopathy of prematurity. Next, breast milk enhances the development and maturation of the digestive tract. It contains special enzymes that improve the bioavailability of macronutrients and trace elements to the infants. And it also provides hormones that improve feeding tolerance by assisting with gastric emptying. Next slide. And then there are also low iron concentration in breast milk that averts microbial overgrowth, resulting in fewer infections. Next. In preterm birth, the mother's mammary gland is still immature with loose endothelial cell junctions that allow more and larger proteins to cross into the milk. These are now the immunoglobulins that are protective. And most of these factors appear to be concentrated in the milk of mothers who deliver prematurely. Next slide. So part of the breast milk section is also a discussion on composition of human milk, support of mother's breast milk supply, fortification of breast milk, the storage and expression and feeding of breast milk, and also a little bit about the management in the context of HIV and AIDS. Next slide. The section on alternative methods of feeding includes gastric tube feeding and cup, spoon, and syringe feeding. Next. Then the annexes may be used as handouts for training of healthcare workers, as job aids for improving correct feeding practices, and tools for the recording of feeding practices and aids for improving clinical practices. Some examples include, next slide, feeding job aids, such as these, which are flow diagrams to assist the health workers when to transition from tube to cup to exclusive direct breastfeeding. Next slide. Then in conclusion, this resource document has many potential applications. Sections of the document can be contextualized according to the needs of a health facility, and the document is available on these different websites. Thank you.
Thank you so much, Dr. Elise, for giving us that wonderful overview. I know there are definitely questions that may be arising from the audience. We really encourage all of us to put those questions and comments in the chat, in the Q&A section, and we will try and answer all the questions as much as we can. So next up, we have Kimberly Manson from PATH, who will be discussing the development of the new WHO human milk banking standards. Welcome, Kim.
Thank you, Emily, and thank you all for your interest in this topic. I see we have so many participants here celebrating World Breastfeeding Week. We've heard both some of the special needs of this population. We've heard about a specific story of a specific setting where a mom received support from a human milk bank. Now I get to bring us back up to the global level to say, where are we even at in the guidelines, or what standards or what information is available in this space? So next slide. Next slide. So as what has been already discussed, the WHO does prioritize mom's own milk for the preterm low birth weight population. In 2022, there was the release of the WHO recommendations for the care of the preterm and low birth weight infant. This re-emphasized guidance that has been there since even 2011, similar guidance that mother's own milk is the primary food for this newborn. But what happens? What is the guidance when early on mom's own milk is not fully available, or in a case of separation at different facilities, or something that has happened where mom's own milk can't reach that newborn? The next available, next priority would be donor human milk from a human milk bank. So a human milk bank specifically is a service established to recruit breast milk donors, collect donated milk, then process, screen, store, and distribute the milk to meet the infant's specific needs for optimal health. The mission of the milk bank, however, is to promote and support breastfeeding by providing safe, high-quality donor milk to fill a gap for those who need mother's milk but cannot receive it. A high-performing milk bank is grounded in many foundational principles, but the primary one is focusing on mother's own milk. So what you see in front of you is a very basic diagram. However, models of milk banking exist through a variety of methods globally. They can be small, only serving one single neonate unit. They can be large centers that are out in the community that are collecting excess milk that has been stored in freezers and providing to many, many hundreds of hospitals. Milk banking models look extremely different, and they also are associated and integrated with lactation support in a very different way. The models and the type of milk bank that has been described here today is one that is within the hospital where mothers are seeing milk donation happening as they're also maybe receiving donor milk support for their own infant as their milk supply is coming in. That specific period and need is a special one, and where breastfeeding has to be protected, and donor milk, the use of donor milk always should be in focus of supporting mom's own milk at the end of the day. Next slide, please. So global standards have been lacking in how to establish a safe milk bank, how they should be operationalized, what they should look like. These are examples of guidelines around the world from different countries in Vietnam, India, Kenya. Everyone has taken a slightly different approach. For example, one model that's shown here from India is the Lactation Management Centers, or the Comprehensive Lactation Management Centers, CLMCs. That's what they call their milk bank, learning from the Brazil model of seeing the milk bank as the house of lactation. So when someone says milk bank or a specific model, really dig into what that actually means, because it can mean something very, very different. But the guidelines on how to do this is quite limited. And WHO, although you saw in the recommendation, promotes the use of donor milk, there is no specific guideline on donor human milk or human milk banking. Next slide. And so there's an increasing momentum to include human milk banking into the care of small and sick newborns, with a point at which we don't yet have the guidance that leads to safe and equitable systems. And so, next slide. We see that the distribution of milk banks globally does not align where the biggest need, where the most premature, highest risk, highest newborn mortality rates are happening. We don't necessarily see exposure and availability of these services. Next slide. There is guidance, however, and history of this being included. So back in 2017, at the World Health Assembly, there was a provisional agenda item on the medical products of human origin for the principles of donation and management of MPHOs. Breast milk was considered an MPHO. So there are principles against protecting donors, allocating that MPHO, the traceability, financial compensation considerations, and the regulatory environment. However, these do not pertain to describing human milk banking and donor human milk in detail. Next slide. So as a part of the effort and the recognition for this need, WHO, in collaboration with the University of Zurich, hosted or sponsored an international expert consultation on the donation and use of human milk. In this meeting, they were looking for identifying our implementation and or guidelines for human milk banking and donor human milk needed. Next slide. The answer was yes for what was identified. And so when funding was available to start this process, WHO started down the guideline development process following the handbook for guideline development. So planning, creating a GDG, a guideline development group. This is a multidisciplinary, geographically diverse group without conflicts of interest, representing both high income, low income, everywhere you can think of, both those in milk banking, those coming from medical products of human origin, microbiology, clinical perspectives, parent perspectives. So a very diverse group coming to formulate what are the key questions needed for recommendations. So there were 2 guideline development group meetings already, and this process is ongoing. There is the development then of the actual guideline, which is now considered a standard. And that process involves taking the key questions that were identified that would be of global interest, including in especially for low and middle income countries, and saying, what do we need to know about donor human milk or human milk banking that will create a safe and nutritional product? So that there is an entire process on identifying the questions, performing systematic literature reviews, compiling the evidence, and then coming back together to determine what can actually be recommended in these guidelines. Next slide. I want to clarify what to anticipate in this process for what will be coming out. So this, right now, the process is underway. In 2025, it is anticipated that there will be the actual release of these standards. But what will the standards actually be? This document will be what donor human milk banks, what they have to do to establish standards as a minimum benchmark. So clear recommendations, concise, based on what is available in the literature. What these standards will not be, which I think many people on this call will actually be interested in, is the how. How do we go about integrating milk banking into lactation support systems, into the hospital, into regional systems in a cost-effective way that can be incorporated with lactation support and not undermining breastfeeding? So I just want to be very clear that what is coming currently in the process is specifically on a safe and nutritional product, but it won't necessarily be all the implementation guidance. It is being looked at as a potential for being jointly developed with UNICEF. Other groups are looking into this, and that is the eventual plan. But right now, it's starting with just the standards. Okay, next slide. So we are currently, we've conducted 2 guideline development group meetings to develop what the questions were, prioritize those, and then next slide. For each sub-question, they were identified. This is an illustrative list that I'll just go through very briefly, but this ranged between anything from minimum requirements for recruiting donors to not prevent harm to the donor mother or her infant, and or the recipient. Then what about the selection criteria in optimizing donation to prevent harm to the donor mother, her infant, and the recipient? What are the minimum requirements for providing donors with education and support on best practices for milk expression? Does that change the end product? What are the minimum requirements for supporting human milk expression in order to achieve a safe and quality product? Next slide. And I'm not getting into all of the sub-questions here. Just high level still, what are the minimum requirements for storage of expressed milk from expression until it is processed at the milk bank? What do milk banks need to require? Number 6, what are the minimum requirements for handling donor milk, including donor milk storage, pre and post pasteurization? How much time can this remain in the milk bank? What containers should be used? What are thawing practices that don't impact the quality of the milk? Number 7, what are the minimum requirements for pooling between donors, individual donors, tracking and tracing, ensuring safety and quality? Number 8, what are the minimum requirements for treatment of donor human milk? Is that pasteurization? Can we be using raw donor milk? In what circumstances? What provides the optimal safety and quality product? Number 9, what are the minimum requirements for donor milk testing to ensure safety and quality? Next slide. Okay, and I'm going to keep continuing on, but it's more of the requirements for the treatment of donor milk on safety, producing something safety and quality. All of these questions were combined, configured and put out for a call for systematic review teams. So the process is currently in effect, that the systematic reviews are underway for these questions. Next slide. These are the 7 systematic review questions that are currently underway that will be going towards the next GDG meeting that will establish the draft guidelines. Next slide. And finally, the steps to actually establish the standards. So once the next review happens, the GDG will meet, guidance is prepared and reviewed by external experts. Finalization, WHO approves, and then there will be dissemination. This is anticipated for 2025, so be on the lookout for that. Next slide. So just to wrap up and to really emphasize, we know that this is just one component. The milk bank itself always should be in alignment with breastfeeding support, lactation support, understanding the needs of this population. This is not donor milk for just anyone in the community that cannot breastfeed, but this is for the most vulnerable of infants that are admitted to a hospital before mother's milk has come in. It holds a very specific use and place. And so there's an urgent need to ensure that the milk bank is implemented as a part of a comprehensive nutrition package of care, prioritizing mothers on milk first. Thank you.
Thank you so much, Kimberly, for that overview of the WHO guideline development for human milk banking. Just a reminder, please continue to add your questions into the Q&A section, and our team will be sure to answer all your questions and comments. So next up, we have Patrick Tor, who is a neonatal nurse and a board member of the COIN. He will be speaking to us about specialized lactation support, the unique needs of small and sick newborns and their mothers. Welcome, Patrick.
Thank you so much, Dr. Emily. I'm going to talk about the specialized lactational support and the unique needs of the newborns and the small and sick newborns. Next slide, please. Next slide. So from our previous presentation, we've seen that the World Health Organization recommends that the mother's own milk is recommended for feeding of preterm and low birth weights, including very preterm and those who are less than 32 weeks. If the mother's own milk is not available, the donor human milk may be considered for feeding of preterm or low birth weight and those who are less than 32 weeks. Despite us having this guidance being provided by the WHO on what to do, gaps still remain on how to achieve the same. So provision of human milk plays a critical role in survival of small and sick newborns. We still have challenges in ensuring access to human milk for this vulnerable population. And that is why we are here today asking ourselves what systems and programming efforts will allow for protecting, promoting, and supporting breastfeeding, even for the most vulnerable of the newborns. Next slide. So we can look at the diagram and we can see there's a gap. So lack of alignment or integration between the nutrition and newborn policies, funding and implementation has resulted in lack of prioritizing systems to meet the unique needs of the small and sick newborns. We can see on this far end, we have nutrition, feeding, and lactation support. And on the other end, we have the newborn care. And in between, there's a gap. We need to bridge this gap for us to be able to improve the quality of care. So we must close this gap with strategic integration of newborn and nutrition to ensure access to human milk for all. Next. So what are these maternal challenges to breastfeeding and lactational support for the small and sick newborns? So in our setups, we have separation of the mother and the newborn, and this could be contributed by several factors. It could be due to maternal diseases. In other instances, we have separation of the mother and the newborn, maybe due to the hospital visitation policy, where we give the mothers the timings for visiting the babies in the newborn units. We also have lactational delay, insufficient milk volume to meet the newborn nutritional needs, and maternal reliance on milk expression for establishing milk supply instead of direct feeding. So all these are the challenges that our mothers pass through. Next. So we are saying in short that these gaps exist in the current care systems, and it starts all the way from the labor ward, our neonatal units, and going to the extent of the discharge. So in the labor ward, we have feeding is not prioritized during transfer to the neonatal unit, and the mother may be delayed. The feeding may be delayed until the mother arrives. There's also separation of the infants. There's also lactational is impacted by the birth complications and lack of support and supplies for lactational support for initiation of feeding. There's also lack of infrastructure to transport express breast milk. In our newborn units, we have cases of prematurity or complications which prevent direct breastfeeding, inadequate small and sick newborn feeding protocols, supplies and cross standards. And also we have suboptimal alternatives if the mother is not present or lactation is delayed. Milk supply also is inhibited by premature complications, maternal distress and separation, and also limited coaching on transition to direct breastfeeding. There's also lack of skilled early lactational support, and expression guidance may be driven by newborn volume requirements rather than optimal lactational practice. Going to the extent of the discharge, neonatal discharge criteria may not include achievement of full feeds or breastfeeding. Hence, we have premature discharge of babies, lack of community-based skill lactational support for at-risk mother and infants. Mother's milk supply may also be inadequate due to lack of early lactational establishment and maintenance, and readmission is highly possible. Next. So we are looking at all these gaps, and we have interventional keys. So we need to have skill lactational support, direct breastfeeding support. We need to have adequate supplies and devices, ensure we have enough donor human milk. We strengthen our protocols and processes, have infrastructure that is working, optimal newborn feeding, and integration and linkages. Next. So for us to ensure the same, we have special lactational needs for small and sick newborns. These are call to action. And the first one is we need to strengthen the policy. We need to establish hospital policies to support NICU staff to undergo specialized breastfeeding support training. We need to create global guidelines to strengthen and specialize lactational support for the NICU setting. We need to enable hospitals to assess cost-effective hospital-grade breast pumps and establish hospital policies to allow for roaming in to ensure frequent maternal access to infant. We also need to enhance NICU training, develop and deliver training programs to NICU staff on benefits of human milk. We also need to train NICU staff on how to fit, use, and clean the breast pump. We also need to train NICU staff on how to facilitate skin-to-skin and non-nutritive suckling while the infant is still in NICU. We also need to optimize our NICU environment through providing communications, advocacy materials on the benefits of human milk pumping and how to feed their small and sick newborns. All these will impact on skill lactational support, on mother and infant diet. So mothers are supported, mothers will have improved access, infant intake of human milk, and the NICU staff's support success transfer to infant feeding. And what will be our goal at the end? Increase exclusive human milk and improve neonatal health outcome for small and sick newborns. So what we are saying in essence is that for specialized lactation support training, it should be feasible, scalable, and in line with ongoing newborn and nutritional trainings. Thank you so much.
So just to continue with on what Patrick had been talking about, the need for specialized lactation support, we have postulated that the things that we need to ensure that we provide mother-centered care that aligns with this provision of specialized lactation support. We have developed the Mother Baby Friendly Initiative Plus as an organization, and we postulate that this would include several components, including specialized lactation support, newborn feeding, maternal and newborn nurturing care, human milk systems that align with overall health system strengthening for lactation support, enhanced follow-up for small and vulnerable newborns, as well as the treatment of malnutrition, particularly in those who are less than 6 months. Next slide. So honing in on specialized lactation support, we know that to support mothers to initiate and build and maintain their milk supply, it's important that we start this support within the first hour of delivery and troubleshoot throughout their stay within the health facility and equip them with the right skills and knowledge that they can use while within the community. Next slide. So our team has been working very closely with USAID through our Digital Square teams, and we have been developing we have developed a specialized lactation support curriculum that would enable healthcare workers within the health systems, particularly in low middle income countries, to support women and their families to provide the appropriate milk for their small and vulnerable babies. And this targeted curriculum builds on other existing curricula, including the neonatal BFHI, BFHI for small and sick newborns, as well as the essential newborn care guidelines. And PATH is developing this curriculum in concert with other healthcare workers, including clinicians, neonatologists, and others, as well as dietitians and lactation consultants. Our long-term aim is to create an adaptable global good that can be used within the health system around the world. And we are using a human-centered design approach to ensure that the product and the curriculum that we develop is fit for purpose. Next slide. So this curriculum will be structured in 3 different ways. And the first way is in the form of mini modules. And these mini modules are about 30 of them, each of them containing information that would enable healthcare workers to support moms within the health facility. So these mini modules are developed in such a way that they can be pulled apart, and so that healthcare workers can use these mini modules to train healthcare workers even while they're within the health facility and through on-job training. Next slide. So in addition to the mini modules, we will also have job aids, and these job aids will be in the form of mother-facing job aids as well as healthcare-facing job aids. And we anticipate that the mother and family job aids will be fairly simple to understand, but they will provide concise information that the mother would need to provide enough milk for her baby. Next slide. In addition, we also have another version of this curriculum that has a potential of being a pre-service certification curriculum. It provides comprehensive modules to establish deep technical skills, and we envision that this can also be used by healthcare workers within the health system, and they would actually receive certification as lactation specialists within the health system. Next. Great. And I think that's it in terms of the presentations. At this point, I will hand it over to Kirsten to run us through the Q&A and closing remarks, noting the time. Thank you so much.
Fantastic. Thank you, Emily, and a huge thank you to all of the speakers today. With that in mind, we have kept well to time, so appreciation there. It leaves us time to have a few minutes for questions and answers. We have a few questions that were posted in the chat, and I think those were responded to. It would be lovely for our panelists to be able to engage in some discussion if there are questions. Feel free to continue posting into the Q&A section on the Zoom link if that is more comfortable for you, but I'll pause for a minute.
Kirsten, I'm wondering if there was a really good question in the chat from Becca Kirby on technology gaps. I'm wondering if we want to also speak to that, but happy if there are other hands. We've also answered in the chat.
Yeah. Maybe we can start with that. I think that is a very important one to call out. There was a question, if you did not see it in the Q&A, asked by Becca Kirby. I can just read it. Are there any technology gaps that present barriers to promoting breastfeeding for small and sick newborns? I think a number of our panelists might have some thoughts on this. Maybe we can start with Kimberly because you answered in the chat as well.
Yes, and I want to acknowledge Elise gives such a good perspective that often the technology is what's getting in the way from bringing mom and baby together to actually provide practice of actually suckling at the breast when possible, as early as is physically and cognitively possible. However, in terms of actually thinking about lactation, the experience of the mom, and the transition process of the newborn back to the breast for the newborn admitted in the facility, thinking about what is that mother's experience? What is she going through from the first hours of birth until, and even if her baby is separated, which ideally would not be happening, what are the things and technologies that are supporting mom and baby together, are supporting the optimal lactation practices and building milk supply, and are supporting baby to get back to the breast. So some of the technologies, and that's a broad word, right? We're talking about innovations of systems that we could be changing. It's not always just a product, but some things to be thinking about are when a mom has given birth and baby is not able to suckle at the breast, how are we mimicking the suction that is of a term infant rigorously, frequently suckling and stimulating the breast to be able to draw in milk, get to secretory activation where copious milk supply comes in, and building that milk supply as if she had a term infant so that she can feed long-term, that her breast, she's programming her breast to be able to feed long-term, not just the small volumes that are required for the newborn while admitted in the first few days, but the later, weeks and months later that baby needs it. And so there are all different technologies, but doing that in a safe way that is easy to clean, utilizing and maximizing hand expression. But what are the teaching technologies? How are we showcasing and teaching moms? How are we actually giving her, if a product is supportive, more research is needed on doing that well so it doesn't undermine breastfeeding, but actually can draw in milk. Is there an appropriate, safer, easier to clean early breast pump that a mom can have access to that is a better cost in these systems? We don't have that yet figured out. And there's been definitely a fear of that because of the way that it can also undermine and get in the way of breastfeeding. So these are things that definitely need to be figured out. But even things as simple as the cup that we're expressing milk into. So just wanted to raise this because I know there's so many ideas here, but wanted to call it out. Especially for the innovators in the room. Thanks.
Great, thank you, Kimberly, and very appropriate given this webinar is co-hosted with the Nest 360 team, and that has been a very significant focus. I think because of time, we are going to close. I want to acknowledge everyone who has participated in this webinar, most especially our mothers. They really help to paint a picture for us related to the very real challenges that they face. We are grateful for their voice, calling out the gap and the opportunity that we have to address this. In this webinar, we focused on why does breast milk matter even more for these vulnerable babies. Human milk has long-term implications for optimizing the care of this vulnerable population, and it must be a priority, not only inpatient, but beyond. So very grateful to this group of collaborators who have attended this webinar and helped to understand what are some key actions perhaps we all could take. We want to close with this slide as a reminder. Last year's 2023 Newborn Toolkit Essay Contest was incredible. There will be another essay contest that will be launched soon on the 26th of August. Please keep this in mind. More information will be coming. It is quite compelling in terms of not only having a voice, but also the awards that come with this in terms of visibility for sharing your voice. So a huge thank you and have a wonderful morning, afternoon, evening, and thank you very much.